The air is black, the bone is white, the soft tissue is gray. And this one here is the one I want you to look at first. This is we're looking from the feet towards the head. So the sides are reversed, the right's on the left's on the right. Here's your jawbone, you know, like this.
Right.
I'm going to start scrolling up. So you don't see anything in the mouth or the dental artifact. As you scroll down, you see how this whole area is kind of indistinctly smudged out. See that? It's kind of weird. You can see how somebody might not be able to really pick up on this, but see how that's that fullness, that area, that bump that I was showing you, that kind of hump. That's that hump.
Mm-hmm. I did just like that when I showed you. I remember.
And as you go down deeper, you don't see it. This is all normal. It's when you come up, you sort of see it right at the epiglottis, right there. So it's into the vallecula, which is kind of between the tongue and the larynx. And as you go up, you kind of lose it in here. This is very indistinct. It's not like you see I want to say that it kind of comes like this, like that.
So that whole area there?
Yeah, the borders are somewhat indistinct. I think even the radiology even comments on that, you know. Let's see here. Yeah, focal asymmetry in the base of tongue on the left concerning for mass. Discrete borders difficult to visualize. Also enlarged cervical node measuring 29 by 18 by 19 under the marker, just lateral to the ICA. And he puts, you know, findings worrisome for base of tongue mass. Squamous cell carcinoma would be the diagnosis to exclude. You know, he said this is worrisome for a metastatic lymph node. So he's right on target. I agree with his call. It's just I can't really tell where the tumor starts and stops. It looks a little diffuse. You see on this sagittal view here, you know, it's like a big thumbprint here. You know what I mean? You can see it's right in the middle of it on that slice. And, you know, it's kind of full. Again, that little hump.
It's right there.
Yep, right there. So, I mean, I would stage this as a T3N1 because I can't really tell this. I always err on the side of upstaging cancers because you don't want to understage a cancer because then you undertreat the cancer. And you don't want to undertreat. You want to go down swinging big time.
Okay.
So I would call this a T3N1. Looks like you just have the one node. Here's the jugular vein. Here's a carotid artery. Here's that mass. And it's kind of just under the size of, you know, bigger than 3 centimeters would make it N2. It's bordering on N2A. You could almost call it T3 N2A. Would be probably, you know, the most aggressive that I would label it as such.
That's the sticking out there.
Yeah, right there. That's the mass. So here's the jugular vein. Here's the carotid artery. This is the muscle, sternocleidomastoid muscle. And this, the reason you know that's a mass, if you look at these here, carotid artery and jugular vein, you can follow those up. They keep going up, 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 up. You can trace them. See them? They're still there. Now trace them down. Now this thing pops up. You follow it, follow it, follow it, follow it, follow it. Oh, it's gone. That meant it was a circle, you went through it, and then it disappeared. That's how you can tell a solid mass from a cylinder. The vessels you can follow all the way down in the neck. Whereas this, you know, you see this little guy here, you know. Let's go back into the room, let's chat some more about what we need to do to get this cured. All right, so oral cavity cancers, or cancers of the mouth, we typically treat with surgery because they're easier to access and radiation is real hard on the jaws. Now, throat cancer, which is what this technically is throat cancer. You know, it's the oropharynx. The base of the tongue is in the oropharynx, which is the throat. Throat cancer is better treated with radiation, plus or minus surgery. Now, this tumor is also HPV positive. That's a human papillomavirus positive. That's the kind of throat cancer that you see in people that are non-smokers, non-drinkers. I forget, did you have a history of heavy smoking, heavy drinking?
No.
Okay.
And, two cigarettes.
Okay. So, you know, HPV positive tumors like yours are more commonly seen in people that have like kind of a mild smoking history. You know, some people come in and, you know, they reek of cigarettes and they got a 70-pack year smoking history and you know they have squamous cell cancer and it's probably not going to be HPV positive. The HPV is the human papillomavirus. It's a ubiquitous virus that is transmitted from kissing You know, I mean, it can be, you know, the Gardasil is the vaccine for it that we have now. But that virus can cause the cells to mutate and in the right circumstance turn into cancer. The upshot of that is HPV positive tumors are very radiosensitive, meaning they respond to radiation better than HPV negative tumors. So that's something that's in your favor.
Have AP
Positive.
Positive. So
Yes.
that's what, did you hear him say? That's in your favor.
That's in your
Yeah.
favor. That's a good thing. I'd rather have that than not have. I'd rather have, I mean, it's crap. But I, you know, if I had to pick one, that'd be better. That'd be a better thing to have than not, because these tumors tend to really melt away with radiation. Now, you've got a lymph node in your neck, a positive lymph node. Even though it's a small one, it still makes this stage 3 cancer because it's spread to the neck. It doesn't mean you're going to drop dead. Okay, it just means that it's a relatively advanced cancer. The thing to understand, it's kind of an imperfect system. You know, if you had one tiny lymph node, it'd be stage 3. If you had one massive lymph node, it would still be stage 3. So there's a little bit of it's not a perfect grading system. So you know, I'm gonna right now I'm gonna stage you as T3N2A, which means, you know, about almost a 4 centimeter tumor in the base of the tongue. So I'm kind of guessing on the measurements. And that mass is right at 3 centimeters. There's just one of them that makes it N2A. Dr. Simmons will get a PET scan, and we'll see how much of it lights up. We may alter that clinical staging, but right now it looks like T3N2A. And that's a little bit of an aggressive staging because, like I said, I don't want to understage you. I've seen that happen, man, where people kind of weenie around. They want to be nice, you know. You don't.
So where do we go from here?
So
radiation
and chemotherapy. And then after you're treated, we will re-image the neck, and we'll see if this lymph node is melted away and is gone, then you're done. If it persists, then we do a neck dissection where I make an incision in your neck and I clean out all the lymph nodes on that side, get any residual cancer that hasn't responded to the radiation out. Majority of time, when you have a tumor your size with that degree of lymph node burden in the neck, we don't need to do a neck dissection. It just depends.
This is huge or not huge?
Not huge. I would say it's middle of the road. Middle of the road.
Now, talk to us about the radiation, the chemo.
Yeah.
The course
What's
of
gonna
it.
happen?
How
Right,
many
so
weeks,
Dr.
how many months?
so
what
it's
are we looking at?
That's a great question. So Dr. Simmons would be the ultimate one to decide that. Usually it's 4 to 6 weeks of radiation. You get radiation 5 days a week. They joke that cancer doesn't grow on the weekends, so you get a break on the weekends. So they give you treatments every day, Monday through Friday, for 4 to 6 weeks, depending on how he protocols it.
This can be where in Gainesville.
We can do it here at Dr. Simmons.
Okay.
Yeah, Dr. Simmons trained in Gainesville.
Now
the
they have
same guys as
the
me.
machines where they localize it.
Yeah, so what we do is he'll get a PET CT scan, and that will look for disease in other parts of your body, making sure it's not spread anywhere else, which I doubt it has. And then with that PET CT scan, he will design a protocol to zap the primary tumor and zap some of the surrounding tissue and then treat the lymph nodes in the neck. And, you know, he'll make that call as how he designs that radiation treatment plan. He has to look at the imaging, look at the pattern, look at the way it lights up on PET CT, and literally draw out a treatment plan, you know, and then you program the machine to go in and deliver the radiation to the areas, the targeted areas in question.
Now that's delivering radiation. Now what's the chemo? It's something you dispense through the whole body.
The chemo is like an infusion. It's typically a platinum-based chemotherapy. I know less about that than I do the radiation because I don't really, you know, not everybody gets chemo, but you're probably going to get chemo because it's a lymph node in your neck, and the platinum chemotherapy helps sensitize the tumor to the radiation. That's an infusion that you get. I'm not sure how often they're doing that these days as far as the protocol, whether it's every week or every couple days. But they'll talk to you about that too. Dr. Marsden, Dr. Sylvester, one of the guys in the oncology